Good evening, Dr. Phil here. Today we will be discussing on ankle block. Indications for ankle block. Anesthesia and/or analgesia for forefoot and toe surgery. Calcaneal and ankle surgery requires a more proximal block. Complications: vessel puncture, nerve damage, intra-arterial injection, and LAST. Clinical issues: pain during ankle block. Due to tight tissue planes and relatively large volumes of LA, administer adequate sedation. Ankle block during GA. If the patient was given neuromuscular blockers, the nerve stimulator will not trigger muscle contractions. Ankle tourniquet is usually well tolerated. Block duration is 10 hours for long-acting LA and 15 hours for long-acting LA plus clonidine. Landmark technique. Posterior tibial nerve. It is the most important and most difficult nerve to block to ensure adequate surgical anesthesia. Position of the patient should be supine with the knee flexed, leg externally rotated, foot in neutral position. Non-stimulating techniques have higher failure rate and slower onset. Aseptic technique is used. Anesthetize the skin with subcut 1% lidocaine. Needle insertion and LA injection. Use a 25 to 50 mm insulated short bevel needle. Attach the needle to a nerve stimulator set at 1.5 mA, 0.1 millisecond, 2 Hz pulses. Approaches. Retrotibial. Draw a line joining the medial malleolus and the posterior border of the calcaneum. Inject just posterior to the posterior tibial pulse, about halfway on the line. Sustentaculum tali refers to the horizontal ridge of bone felt 1 cm distal to the medial malleolus. Palpate the inferior border of the sustentaculum tali and inject here where the tibial nerve runs just inferior to it. Useful approach in patients with a non-palpable posterior tibial pulse, such as in patients with peripheral vascular disease. Success rate approaches 100% and may be more reliable than a retrotibial approach. Advance the needle perpendicular to the skin in either approach until plantar flexion of the toes is observed on nerve stimulation. Manipulate the needle until stimulation is lost at 0.3 to 0.5 mA and inject 5 ml of levobupivacaine 0.5% after negative aspiration. If the needle encounters bone, withdraw it 1 to 2 mm prior to injection of LA. This nerve can also be blocked in the popliteal fossa. Deep peroneal nerve block. Position of the patient is supine with the knee extended, leg in neutral position, foot is slightly plantar flexed. Use aseptic technique and anesthetize the skin. Needle insertion and LA injection. 23 to 25 gauge needle inserted at 90 degrees to the skin until bone is contacted. Withdraw 1 to 2 mm and inject LA. Approaches. At the intermalleolar line between the tibialis anterior tendon and extensor hallucis longus tendon, inject 5 to 10 ml in a fan-like manner. At the mid-tarsal level, block the deep peroneal nerve between the tendons of the extensor hallucis longus and extensor digitorum longus, where it lies lateral to the dorsalis pedis artery. Inject 3 to 5 ml of levobupivacaine 0.5% medial and lateral to the artery deep to the fascia. Superficial peroneal nerve block. The patient should be supine with the knee extended, leg in neutral position and the foot slightly plantar flexed. Use aseptic technique and anesthetize the skin. Approaches. At the ankle level, at the anterior border of the tibia and lateral malleolus, or at the mid-tarsal level, insertion point is as for deep peroneal nerve block to the plantar junction medially. Needle insertion and LA injection. Use a 23 to 25 gauge needle. Infiltrate a subcutaneous wheal between the anterior tibia and the lateral malleolus with 5 to 10 ml of LA, such as levobupivacaine 0.5%. Sural nerve block. The patient should be supine, knee extended, leg internally rotated, and the foot slightly plantar flexed. Use aseptic technique and anesthetize the skin. Landmarks includes the lateral malleolus and the lateral border of the Achilles tendon, Use a 23 to 25 gauge needle and infiltrate a subcutaneous wheal between the lateral malleolus and the Achilles tendon with 5 mL of LA. Saphenous nerve block. Position the patient supine with the knee extended, leg in neutral position and the foot slightly plantar flexed. Use aseptic technique and anesthetize the skin. Needle insertion and LA injection. Insert a 23 to 25 gauge needle 1 cm proximal and 1 cm anterior to the medial malleolus and inject 5 mL of levobupivacaine 0.5% subcutaneously around the long saphenous vein. The long saphenous vein may be visible at this point. Avoid direct injection into the vein. Ultrasound technique. Advantages over nerve stimulation. There is decreased risk of intravascular injection, seizures, and temporary paresthesia. There is decreased need for supplementary opioids, supplementary LA or conversion to GA. There is increased success. Surgical anesthesia. Ultrasound versus landmark technique. Success 84% versus 66%. Tibial nerve block under ultrasound versus landmark technique. 72% versus 22%. Sural nerve block ultrasound versus landmark. 94% versus 56%. And in cases where vascular landmarks are not easily palpable, ultrasound technique will be advantageous. Posterior tibial nerve block. The patient position should be supine with the knee flexed, leg externally rotated and the foot in neutral position. Use a high frequency 10 MHz linear probe set at 1 to 2 cm depth. Needle choice is a 50 mm short bevel needle. Use aseptic technique and anesthetize the skin with subcut lidocaine. Technique. In-plane or out-of-plane approach can be used. However, the in-plane approach is awkward as the needle is impeded by the medial malleolus anteriorly and the bed posteriorly. Move the probe proximally to improve access to the nerve. Place the transducer transversely at the level posterior and superior to the medial malleolus and identify the structures as shown. The medial malleolus has a hyperechoic periosteum with a dark underlying shadow. Tibialis posterior and flexor digitorum longus tendons lie beneath the flexor retinaculum. Tendon of the flexor hallucis longus lie deep and posterior to the nerve. Unlike nerves, tendons have a sliding movement with ankle flexion. Tendons will develop into their respective muscles when scanning proximally, but nerves do not. The tibial artery is pulsatile on color flow Doppler. The tibial nerve is predominantly hyperechoic. It may be honeycomb, round or oval in shape. The veins may be present adjacent to the artery of the nerve. Nerve stimulator helps in identification of the nerve. Inject 3 to 5 mL of LA around the nerve circumferentially. Deep peroneal nerve. Deep peroneal nerve block. The patient should be supine with the knee flexed, leg in neutral position and the foot slightly plantar flexed. Ultrasound settings. Use a high frequency linear probe set at 1 to 2 cm depth. Use a 50 mm short bevel needle. An aseptic technique should be used. Anesthetize the skin with subcutaneous lidocaine. Technique. Place the transducer transversely above the intermalleolar line on the anterior aspect of the leg. The structures seen are as shown above. Dorsalis pedis artery is pulsatile. Color flow Doppler helps with its identification. Avoid obliterating the artery by excessive compression from the probe. The deep peroneal nerve is a hyperechoic circle lateral to the artery. Use in-plane or out-of-plane approach. Inject 2 to 3 mL of LA around the nerve or on either side of the artery if the nerve is not seen clearly. Superficial peroneal nerve block. The position of the patient should be supine with the knee flexed, leg in neutral position and the foot slightly plantar flexed. Use a high frequency linear probe set at 1 to 2 cm depth. Use a 50 mm short bevel needle. Aseptic technique should be used. Anesthetize the skin. With the transducer placed transversely on the lateral aspect of the proximal lower leg, the above structures can be seen. In-plane or out-of-plane approach can be used. The superficial peroneal nerve is a large lateral branch of the common peroneal nerve. It can be seen entering the peroneal compartment under the peroneus longus. It then emerges superficially and lies between the peroneus longus and the extensor digitorum longus. Ascertain whether it is above or below the crural fascia. At the level of the ankle, the terminal branches of the superficial peroneal nerve are not visualized consistently. Aim to inject 3 to 5 mL of LA circumferentially around the nerve. Ensure that LA is injected on the correct side of the crural fascia. Sural nerve block. The patient should be supine with the knee flexed, leg in neutral position and the foot slightly plantar flexed. Use a high-frequency linear probe set to 1 to 2 cm depth. Needle choice should be a 50 mm short bevel needle. Use aseptic technique and anesthetize the skin. Technique. Place the probe transversely at a mid-calf level on the lateral aspect of the lower leg. The sural nerve can be seen between the medial and lateral heads of the gastrocnemius muscle, where it emerges piercing the fascia lata. It then descends with the lesser saphenous vein within the subcutaneous tissue of the lateral aspect of the lower leg. It is seen as a hyperechoic circle immediately adjacent to the vein. Lesser saphenous vein can be made prominent by applying a tourniquet proximally. In-plane or out-of-plane approaches can be used. Inject 3 to 5 mL of LA circumferentially around the nerve. Saphenous nerve block. Position the patient supine with the knee flexed, leg slightly externally rotated and foot slightly plantar flexed. Use a high-frequency linear probe set to 1 to 2 cm depth. Needle choice should be a 50 mm short bevel needle. Aseptic technique should be used. Anesthetize the skin with subcut lidocaine 1%. Technique. Place the probe transversely at a level proximal and anterior to the medial malleolus. The saphenous nerve emerges from between the sartorius and gracilis and descends down the medial edge of the tibia immediately posterior to the great saphenous vein and lies anterior to the medial malleolus. A proximal tourniquet will make the vein more prominent. In-plane or out-of-plane method can be used. Inject 3 to 5 mL of LA circumferentially around the nerve. Perivascular LA injection can be made around the great saphenous vein if the nerve is not visualized clearly. These are my references. Thank you.